Dr. Ken Landau, thanks for watching. Let's talk about BPH, benign prostatic hyperplasia. Now, this is a histologic diagnosis. It means that there are a lot of big glands inside the prostate. It doesn't have anything to do with the presence of symptoms. We also have another condition, and it's known as benign prostatic enlargement. That's enlargement from any cause, including the BPH. But it also means that it could be from prostatitis or inflammation or infection. But the symptoms that people complain about, those are what are referred to as lower urinary tract symptoms, or LUTS. And those symptoms can be due to BPH, but they're not specific for BPH, and they're present even in women. Now, if we look at benign prostatic hyperplasia, or BPH, the histologic diagnosis, we're going to find that in about a quarter of all men in their 40s, about half of all men by age 50, and about 80% of men by age 80. On the other hand, the symptoms, those lower urinary tract symptoms, they're only present in about 30% of men who are over age 55, about half of men once they get to be over age 65, and then about 90% of all men who make it to age 90. Now, most people who develop lower urinary tract symptoms develop more than one symptom. At the present time, we think that there are tens of millions of people who have benign prostatic hyperplasia. Once they go to see the doctor, about a third of them are just observed, about half of them get some kind of medicine, about 10% stop the medicine, and only about 1% are going to go on to undergo some sort of surgical procedure. Now, the size of a normal prostate is between 15 and 30 milliliters. That means between 1 and 2 tablespoons. When it's more than about 30 milliliters in size, that's what we call being enlarged. Now, the prostate surrounds the urethra. That's the tube that goes from the bladder to the outside. And when you have development of BPH, those glands get larger, they can actually kink the tube. When they kink the tube, that's when you can get some symptoms. Now, the purpose of the prostate, what does it do under normal circumstances? Well, it causes secretion of an alkaline milky substance, and that alkaline milky substance makes up about a third of the volume of the semen. The prostate has glandular tissue, but it also has a lot of other kind of tissue, some fibrous tissue, some connective tissue, and it has some muscle tissue, and then it has a capsule around it, and that again has the connective tissue and the smooth muscle, and all that's going to be important when we talk about the symptoms and how we treat them. Well, the prostate can be divided into different zones. We didn't really know about that until the late 1960s. There's the non-glandular anterior zone toward the front. That's just made up of connective tissue and muscles. And then we have the glandular tissue. We have the peripheral tissue. That's where the cancers tend to develop. And then we have the central zone of the prostate that surrounds the ejaculatory ducts, and then we have the transitional zone. That's what we're interested in, because that's where the BPH, or the benign prostatic hyperplasia, tends to occur, and that's the area all around the urethra. Now, the benign prostatic hyperplasia signifies that we have some problems in the transitional zone with the glandular elements and also the stromal elements. Those are the other elements, the fibromuscular, the connective tissue, and the smooth muscle. And all of that may lead, in some men, to those lower urinary tract symptoms, or the LUTS, which can be themselves divided into the obstructive family and the irritative family, or you could have both. Now, it's very important to realize that neither the presence of BPH nor the presence of those symptoms have anything to do with your risk of developing prostate cancer. So if we divide the LUTS into its two primary parts, we have obstructive symptoms. That means urinary hesitancy and a weak stream and straining to void and a delay in the initiation of the stream where you stand in front of the urinal for a long period of time. You have involuntary interruption of the stream and prolonged, slow voiding. Those are the obstructive symptoms. Or you could have the irritative symptoms, which are also referred to as storage symptoms. So you have increased frequency and have urgency and a decreased voiding volume. Have to get up at night. Have urge incontinence where you can't make it to the restroom in time. Sometimes you have dysuria. And after you finish urinating, you can dribble, or you can have incomplete emptying of the bladder, so you have to go again within less than a period of about 2 hours. And these symptoms obviously can be disruptive to your social life and your spouse's ability to sleep. It can cause some psychological problems. And lower urinary tract symptoms are more complex than just simply having benign enlargement of the prostate, because those same kind of symptoms can come from problems with the bladder. So you might have an underactive bladder, you might have an overactive bladder, and it all depends on the receptors for the different chemicals that happen to be on the bladder or in the prostate. Might have to do with pelvic ischemia from atherosclerosis. So all of that can cause same kind of symptoms and has to be sorted out before you get treated, certainly before you get surgically treated, because you might find that the diagnosis isn't what you think, since the symptoms are all the same. So if we look at the prostate, we have a substantial portion being smooth muscle, and the smooth muscle has contractile properties. You can have active contraction or you can have passive contraction. And the contraction has to do with impulses from the nervous system. So that's very important, because that means that the symptoms aren't always the same. So when we talk about the symptoms, they could either be static or they could be dynamic. Static means that you have the glands that are enlarged and they cause the symptoms all of the time, but you could have the dynamic symptoms, and those symptoms tend to get better or tend to get worse depending on a variety of other factors. So the static symptoms, those are from the glands. The dynamic, well, they're mediated by those smooth muscles and the receptors. And we have a variety of different kinds of receptors on the smooth muscle cells. We have receptors for the adrenaline or noradrenaline, norepinephrine. We have the muscarinic receptors for the acetylcholine and the phosphodiesterase inhibitors. Now, there are certain risk factors that go along with having benign prostatic hyperplasia. And some of those are your age. The older you are, the more likely. Your genes, the geography where you live. But some are modifiable. And those have to do with your sex, steroid hormones, and the metabolic syndrome, and your body weight, and whether you have diabetes, or whether you exercise or don't, and whether you have cardiovascular disease. And now, just since the 1990s, we're realizing that inflammation inside the prostate has an awful lot to do with the symptoms. So every year, your prostate's going to increase slightly. It's going to increase by about 0.5 to 0.6 milliliters. So about half a milliliter, or a little bit more, going to increase. Now, some people it decreases, other people it increases a heck of a lot more. But the overall average change is going to be about 2.5%, increase by about 2.5% per year. But you have to realize that there's no direct correlation between the volume of your prostate and the severity of the symptoms. Now, it seems that people who have the metabolic syndrome is when you have high blood pressure and you're elevated cholesterol, and maybe you have high blood sugar and central obesity, big waist, and insulin resistance. Well, those people have changes that are unique as far as BPH is concerned. They're going to have larger prostate volumes. Those individuals who have the metabolic syndrome, who have the conditions that I just mentioned, are going to find that they're more likely to have benign prostatic hyperplasia, and they're going to have more rapid growth of the size of the prostate. But again, remember that the size isn't necessarily correlated with the symptoms. Now, those people who have the metabolic syndrome and have diabetes, we find that diabetes also affects the bladder. And it causes bladder overactivity or bladder underactivity. And also, those people with metabolic syndrome and people with diabetes have a higher risk of atherosclerosis that can affect the bladder, causes hypoperfusion, less oxygen gets to the bladder. So remember that those lower urinary tract symptoms that you associate with BPH can have a wide array of causes, not solely attributable to BPH. So obesity increases the adipose tissue, and we know that there's a direct correlation between the prostate volume and how much you weigh. So it appears that if we look at your waist-hip ratio, for every 0.05 points increase in your waist-hip ratio, you're going to have about a 10% increase in your BPH and the likelihood of having severe BPH. So we find that as you go from normal weight to overweight to obese to severely obese, your prostate is going to similarly increase in size. So in severely overweight people, severely obese people, the prostate might be 3 times as big. And it also seems to be related to the fasting blood sugar level and to the presence of diabetes. So the proposed reason for this interaction, well, seems to have something to do with systemic inflammation and inflammation directly in the prostate, and also oxidative function. So genes are very important, of course. So if we look at relatives of men who have undergone surgery for BPH, those men have a 4-fold increase in their likelihood of having BPH and having to undergo surgery. We look at monozygotic twins, much greater correlation than dizygotic twins. So hereditability might account for as much as 50% of the risk. And we know that there are certain genes that seem to be associated with more aggressive types of BPH. Now, the symptoms are going to increase if you drink alcohol or caffeine or take a diuretic, and certainly in those people who take a first-generation antihistamine like Benadryl or the anticholinergic medicines like Bentyl that's very frequently used for the irritable bowel syndrome. People who take the beta blockers, calcium blockers, going to worsen. Well, what's the pathology? The pathology has to do with the transition zone, and it seems that the glands in the transition zone are under the control of the sex hormones and inflammation. Now, it does require testicular androgen, male hormone, testosterone, to mature the prostate. So if we castrate an individual in youth, those individuals are going to have tiny prostates throughout their entire life. But once you get to be adults, then the influence of testosterone on the prostate is somewhat less. And as a matter of fact, the level of testosterone in the system is going to be about stable between the ages of 25 and 60. That's during a time when the prostate is growing in size. When you're developing the BPH, testosterone stays the same. So we have the testosterone effect that seems to be linked to an enzyme. And the enzyme is known as 5-alpha reductase. And it converts the testosterone to dihydrotestosterone. And it's the dihydrotestosterone that works inside the prostate and makes it get bigger. But there's another enzyme known as aromatase. And aromatase is going to convert the testosterone to the female hormone known as estrone. And the prostate seems to have receptors for the estrogen receptor, and there are 2 types, the estrogen receptor alpha, that seems to be mostly in the stroma, that's the connective tissue and the muscle, and then we have the estrogen receptor beta, and that happens to be mostly on the epithelial cells and in the glands. So what is the effect of the testosterone, the sex hormone, on the prostate? Well, in those individuals who have BPH or who have the symptoms of LUTS, those people tend to have a low, not a high testosterone. Let's repeat that. They tend to have a low, not a high level of testosterone and a high level of estrogen. So in rabbits fed a high-fat diet, well, it seems that's going to lead to the metabolic syndrome, and with the metabolic syndrome is going to cause hypogonadism. And hypogonadism is going to cause an increase in the amount of estrogen, going to have some fibrosis and some hypoxia of the prostate, inflammation of the prostate. And as a matter of fact, if in those animals we give them testosterone supplements, it's going to normalize the prostate. And in men who are obese, who have low levels of the good cholesterol, the HDL, high levels of the triglyceride, high levels of insulin, Well, those men are going to develop inflammation of the prostate, and if we give them testosterone, that's going to normalize some of those changes. Now, the dihydrotestosterone, the DHT, inside the prostate is going to increase some of the growth factors, the factors that lead to cell proliferation, epidermal growth factor and keratinocytic growth factor, and insulin-like growth factor, and all of that is going to increase the likelihood that the prostate is going to grow in size. There are other hormones like serotonin and vanillic acid. They're going to decrease the androgen receptors inside the prostate. And then there's a very commonly used drug called metformin. Metformin seems to be able to maybe lower the testosterone, and it's unclear exactly how it works, but it decreases the insulin-like growth factor and its receptor, and it might be that metformin, the drug that we use for treating diabetes, treating the polycystic ovary syndrome, might actually be helpful in treating people who have enlargement of the prostate. So if we look at people who have equally sized prostates, and we look at their symptoms, if they have a little bit of inflammation, they're going to have not terribly much bother. If they have a lot of inflammation, they're going to have a significant amount of bother. And if we biopsy the prostate, and those people who have symptoms, we're going to find that they have an increased level of inflammatory cells. We call those lymphocytes. They're going to have the T lymphocytes, going to have the B lymphocytes, they're going to have the macrophages. So we have to make certain that we don't link the BPH to the symptoms, those lower urinary tract symptoms, but we relate both of them to the presence of inflammation. And there are a lot of different chemicals we won't talk about that seem to be involved in the inflammatory process, but this wasn't even linked until the 1990s. And now it seems that we can relate the symptoms and the inflammation to the metabolic syndrome and obesity, and certainly to infection with either viruses or bacteria. And all of those things, all of those items, all of those issues are going to increase the production of growth factors and cause some symptoms. Well, let's talk about how we rate whether you need any kind of treatment or not. The American Urology Association has what we call a symptom index, and you could have anywhere between 0 and 35 points. Difference in 3 points is deemed significant. There are 7 questions regarding the presence of symptoms. Now, the International Prostate Symptom Score, that just adds a question about the quality of life. So in the report, or in the questionnaire, in the index, they ask for questions about how often you get up at night to urinate, how often you need to urinate again within 2 hours, whether you have a sense of incomplete emptying of your bladder. Do you have a difficult time starting the stream? Does the stream seem to be interrupted, or is it weak? Those are the questions that are answered on a score of each question, 0 to 5. That means that you have mild symptoms if you have anywhere between a score of 1 and 7. Moderate symptoms if you have a score anywhere between 0 and 19, and severe symptoms if you have a score of over 20. But remember, the score just measures whether you have lower urinary tract symptoms. It does not tell what the cause is. So it doesn't say whether you have an infection, whether you have retention, whether you have some problems with your bladder, overactive, underactive. All of those symptoms can lead to the same kind of score. So how do we evaluate the individual? Well, history and physical examination, of course. Check with the fluid intake, the fluid volume charts, the volume and the frequency that you urinate. So when do you drink and when do you urinate and how much do you urinate? We do that over a 3-day period. Feel the prostate, feel its volume and shape and consistency and nodularity. Look at a urinalysis, or look at the urine to check to see whether a person has urinary tract infection. Maybe check the post-voiding residual volume. So after you finish urinating, there's still some urine in the bladder. Normally, it's going to be less than about 3 to 4 tablespoons. Could be that much. Sometimes could be up to 100 milliliters. And that would be about 7 or 8 tablespoons. Well, if a person has a lot of urine left, maybe 200, 300 milliliters left. And that might mean that the bladder outlet obstruction is severe, or it might be that your bladder wall isn't working well. Well, we could do a transabdominal ultrasound examination to find out how much residual urine there is, what the situation is. American Urologic Association says it's optional. According to the European Urologic Association, they say that should be done as a routine. Urinary flow, how much urine you're able to get out in a timed period. The American Urology Association says doesn't really need to be part of a routine examination. In Europe, they say that's part of the routine examination. How much urine should you get out? Well, if you're a man over age 50, 10 to 15 milliliters a second, in other words, maybe about 2 or 3 teaspoons every second, is how much you should be able to urinate, as long as you urinate a volume of at least 150 cc's, or 150 milliliters. Well, if you happen to not be able to get out more than 10 milliliters a second, you've got issues. So check the PSA. The PSA seems to go up as the size of the prostate increases, and it's not necessarily directly related to prostate cancer. So there are two issues, at least, for increase in the PSA. Certainly if the PSA is very high, it's unlikely to be due to benign enlargement of the prostate. Imaging, it's not routine, but if a person has a history of urinary tract obstruction or stones or kidney problems, renal insufficiency, or if there's blood in the urine, then it might be appropriate to do some kind of imaging test. Transrectal ultrasound examination can assess the residual volume after you urinate, can assess the volume of the prostate. And in some people, for some reasons, it might be appropriate to do a CAT scan or an MRI, but they're not routine, nor is ureteroscopy, where they slip a tube into the bladder and look around. That's not done unless there's some other abnormality. You should see a urologist, obviously, if you have some sort of significant abnormality, if you have a history of prostate cancer, you have a very high PSA, or you have some red blood cells in the urine, or a history of stones either in the bladder or the kidney, or stricture or Parkinson's or prostatitis. So now we get to a treatment. What is the appropriate treatment? Well, we first have to decide what the burden of the symptoms are. And for many people, especially if the score on that index is less than 7, we don't really have to do anything. Assuming there are no complicating factors, minimal bother, maybe even moderate symptoms, less than moderate symptoms, do nothing. Maybe alter the fluids you take and when you take the fluid in. Watch out for the caffeine and the alcohol in the evening. Avoid constipation, because that can worsen things. Avoid the decongestant. So if you happen to take Claritin, you take Claritin instead of Claritin D, or Allegra instead of Allegra D. You be careful of certain medicines that might make the symptoms worse. Other medicines like the Benadryl, you decrease the salt intake, you urinate on a relatively regular basis, and don't drink a lot of liquid for the 2 hours before you go to bed. It's possible that if you change your diet, it might alter the prostate. So if you have a lot of polyphenols and flavonoids and isoflavonoids, in other words, if you have a lot of fruit and vegetables, might be helpful. Well, when it comes to medicines, medicine should be used to improve the symptoms, to decrease the progression, and improve the quality of life. And you have to remember, as far as the treatment is concerned, that we have two different components. We have the static component, that has to do with the size of the glands. That's not going to be changed with rapid order. And then we have the dynamic symptoms. It has to do with the smooth muscles. Those can change very quickly. Firstly, saw palmetto. Saw palmetto is an herb, Serenoa repens, American dwarf palm tree. It's been used ever since the 15th century BC. It wasn't good then, and it's still not good now. It's been studied and studied and studied. Millions of men use it, but the studies all show that it works the same as a placebo. Now, on the other hand, we have the alpha-1 antagonists. These were originally brought out as medicines to control the blood pressure, but that didn't pan out very well. So since about 1992, these medicines have been used to help with the flow of the urine. medicines originally came out, Hytrin or Cardura, and then we have tamsulosin or Flomax or Rapaflo or Uraxatrol. These have rapid onset. They decrease the symptom within several days. The time to maximum effect of the drug might be as long as 4 weeks. They increase the rate of urinary flow by about 25%, decrease the symptoms by about 30 to 40%. So they can decrease the index score that we talked about by 4 to 6 points. And remember, anything more than 3 points is considered clinically important. They increase the bladder capacity, and they decrease the overactivity of the bladder, where the bladder tends to go into spasm. And interestingly, the PDE5 inhibitors might be very useful. This means Cialis. Cialis at a low dose, 5 milligrams a day. That's the medicine used for erectile dysfunction. Well, there are receptors throughout the prostate tissue and the bladder muscle and the vascular smooth muscle that are meant to react with drugs like Cialis. So it relaxes the smooth muscle in the bladder neck and in the urethra and in the prostate, increases the tissue perfusion, modulates the autonomic nervous system overactivity. So along the way, it seems to also decrease the inflammation in the prostate and improve the voiding. So it can improve that index by about 4 points. And then as far as the glandular tissue, so far we haven't addressed the glandular tissue, we just addressed the smooth muscle. Well, if we look at the 5-alpha reductase inhibitors, the drugs that prevent the conversion of testosterone into dihydrotestosterone, drugs like finasteride or Proscar, came on the market in 1992, or Avodart that came on in 2001, they take about 4 to 6 weeks to become effective and take about 3 to 6 months to reach the maximum effect. But they can shrink the glands of the prostate by about 25%, decrease the score, that index score, by about 4 to 5 points. And they also decrease the chance that a person will develop acute urinary retention. That's unlike the alpha blockers or unlike the PDE5 inhibitors. And as a matter of fact, a combination of one of these drugs, either the Proscar or the Avodart, with a drug like Flomax or Rapaflo or Uraxatrol, that's even better than using the drugs separately. And then there's another class of medicines. And these medicines work on the bladder muscle themselves. So the bladder muscle, it seems that it can be overactive. And when it's overactive, it can cause a person to urinate a lot of small volumes. Well, medicines like oxybutinin or tolterodin or Vesicare or mirabegron, those medicines might be somewhat helpful. And a combination of those medicines and the Flomax or the Rapaflo seem to be especially helpful. And for those people whose primary complaint is they just get up at night to urinate, well, we might have a different kind of medicine known as desmopressin, and that might be helpful. So we have to choose the medicine depending on what the major symptom is. Now, unfortunately, left untreated, the prostate symptoms tend to get worse over time. So about 6% of the time, they're going to get worse by about 6 months. About 13% of the men are going to get worse by a year. About a quarter of the men are going to get worse in 2 years, and 30% are going to get worse in 4 years. And the progression isn't uniform across all men. So the progression seems to be more in older individuals, people who are more obese, people who have bigger prostate size, people who have more inflammation or significant depression, mental depression, people who have slower urinary flow, people who have increased residual volume after they urinate, people who have a higher index score. Those people tend to get a little bit worse, a little bit more rapidly. Well, the progression can be halted, actually can even be reversed if we take an alpha blocker or if we take a 5-alpha reductase inhibitor, the Proscar or the Avodart. Between 30 and 40% reduction. If we combine the drugs, maybe a 60 to 70% reduction. Now, some people are unresponsive to the medicines, and the people who are unresponsive are, well, oftentimes not compliant with therapy. So we know that the alpha blockers, medicines like the Flomax, about a third of the people are not going to comply with therapy. About 15% not going to comply with therapy if they're taking the Proscar, and about 10% not going to take both when they're prescribed. And it also has to do with some of the density of the receptors for those particular chemicals on the prostate tissues or in the bladder. And it's not uniform through everyone. And it seems that if we look, just say, at the 5-alpha reductase enzyme, well, as many as 30% of individuals don't express the type 2 isoform because of some epigenetic abnormality. Epigenetics turns off the gene. And when that happens, then unfortunately you're not going to get the benefit of taking the medicine. Well, it also has to do with inflammatory condition. And the more inflammation there is, greater angiogenesis that's going to occur, more of those chemicals going to occur, and those chemicals are going to be growth factors, and they're going to increase the size of the prostate. Well, another issue is Botox. Botox has been around since 2003. As far as the prostate's concerned, people have been looking at it. But unfortunately, even though some early studies suggested that injection of Botox directly into the prostate would be able to reduce the pull of the muscle, the contraction of the muscle, doesn't seem to be effective, doesn't seem to be any different from placebo. So then we're left in about 1% of the people, we're left with some kind of a surgical procedure. And a surgical procedure would be a failure of the medical therapy or refractory urinary retention, or people who have recurrent urinary tract infections, or people who have problems where they have renal insufficiency and red blood cells in the urine and other kind of problems that are related. So there are 3 types of therapy. One is compression of the prostate laterally, just push it aside. Other is to debulk the adenoma, and the other one is to remove the adenoma. Well, it's important to make the correct diagnosis, of course, because somewhere between about 10 and 40% of the people, 10 and 40% of the people who have those lower urinary tract symptoms have them because of detrusor underactivity or overactivity. And certainly if a person has a problem with the bladder instead of the prostate, then treating the prostate isn't going to get them any better. So more appropriate evaluation in people certainly under age 50 or over age 80. So we have the UroLift, where the prostate can be compressed laterally. It's an outpatient procedure. It preserves your sexual function, increases your quality of life. Stable for about 2 to 5 years, but people often have to continue taking the medicines. Then we have the debulking procedure, the transurethral resection of the prostate, or the TURP. This is a treatment that's been around for a long time. We know the side effects, but it's a major procedure and has some problems with it. You have to be an inpatient. It takes 2 to 3 days of hospitalization. There's some bleeding and acute urinary retention that might develop, and you can develop some blood clots inside the bladder that can be difficult to get rid of, urinary tract infection. Well, there are some other procedures. There's the transurethral needle ablation, the tuna procedure. And then we have the TUMT procedure, transurethral microwave thermotherapy. Those never really gained any traction, but we have the transurethral incision of the prostate, and we have the transurethral vaporization of the prostate, and we have aqua ablation with high pressure jets that are associated with the surgical laser that's European Union only in 2018 said, okay. We have water vapor therapy, the Rezum, and we have the thermal energy generated by radio frequency, where a needle is put into the prostate and some waves, some radio frequency waves are put out, have 9-second bouts over a short period of time. Then we can put a needle into the artery and thread it to the area where the artery goes right to the prostate and embolize that. We can cause the prostate to shrink down. That's got some other complications associated with it. It's not very popular. And then we have the adenectomy. The adenectomy, that's the laser enucleation with the holmium laser. That seems to be pretty good, but it's a technically more difficult procedure. Well, even after you've gone through the surgery, estimated about a third of the people still can have some voiding dysfunction. So just going through the procedure doesn't necessarily guarantee that you're going to be better. So the moral of the story is medical therapy first, altered lifestyle first, and only then some sort of surgical intervention. Now, a lot of the surgical procedures are relatively new, and we don't have really any long-term knowledge about whether they're going to have durable effects or not. So certainly you want to make positive that if it's recommended that you undergo surgery, you go to the internet and see how long the surgery's been around and see what kind of results over a period of time, not just over a period of a year or 2 or 3. If you happen to be 60 years old, you're going to be around for 20 years most likely. So see how long the procedure provides the benefits. So that's the story with BPH and with the lower urinary tract symptoms. Basically all men in their 50s and 60s are going to develop some kind of symptoms that are related to enlargement of the prostate and to the lower urinary tract symptoms. Once upon a time we thought it was relatively simple. It was just glandular enlargement, so shrink the gland. But now it seems to be a complicated issue. It involves the nervous system and the smooth muscle and inflammation. And not only the male hormone, but the female hormone as well. And the medical treatment, well, it's helpful, but remember, it's not curative. And the surgical therapy with the traditional TURP, it seems to be losing favor because of some of the side effects and because of the unpleasant effects of the procedure. And other less tried and true treatments seem to be winning favor, but they often lack the durable results that we're talking about. So anyway, thanks for watching. If you enjoyed the show, please tell a friend and consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.